Welcome to another Journal Club session. My name is Ilana Weber, and today I will take you through another interesting and important topic in caring for hospitalized children. Remember to watch this with colleagues to discuss the reflective questions at the end. Let's go! This month's article is looking at pediatric pain. It is titled Landscape of Pediatric Pain in Sub-Saharan Africa, a Scoping Review. It was written by Bhettay et al. And published in the journal BMJ Public Health in 2025. The study highlights the pediatric pain in Sub-Saharan Africa as a significant and unique public health issue. The region faces a high prevalence of conditions with a heavy pain burden, including sickle cell disease, HIV/AIDS, cancer, and injuries. Access to pain management is recognized as a fundamental human right by the Declaration of Montreal and is a global health and equity imperative according to the World Health Organization. Despite global recognition, children in low and middle-income countries suffer disproportionately from poorly managed pain. Pain is complex and influenced by biopsychosocial factors such as context and culture. Suboptimal pain management leads to serious consequences such as delayed recovery, prolonged hospitalization, increased healthcare costs, absence from school, post-traumatic stress disorder, social isolation, and the development of chronic pain. Unrelieved pain also has a clear social and financial impact on families and society. While knowledge of pediatric pain has grown globally, literature specifically from Sub-Saharan Africa remains sparse, with no comprehensive narrative detailing regional experiences and practices. The study therefore aimed to describe pediatric pain in Sub-Saharan Africa by identifying and characterizing available research, which included the prevalence of pain, health system factors, pain management practices, as well as barriers and facilitators, all of which to identify future research directions. The authors conducted a scoping review using the PRISMA guidelines as it allows for broad exploration of studies using varying methodologies. The researchers searched 8 major databases from the year 2000 to 2022. The search strategy combined terms related to pain, location, and age. They also used reverse bibliography, where they checked the reference list of found articles and Google Scholar to find additional citations. Literature from all countries within Sub-Saharan Africa related to pediatric pain were included, and studies involving children from birth to 18 years as well as their caregivers and healthcare providers. Studies that were published in English and French were included within settings such as inpatient, outpatient, emergency department, and operating theatres. They excluded studies that looked at pre-hospital obstetric, community health, and palliative care research. 2 reviewers independently screened titles and abstracts to ensure they met the criteria, with a 3rd reviewer handling French abstracts. For conflict resolution, any disagreements between reviewers were resolved through discussion. Data was extracted using Covidence software and included details on study design, population, key findings, and implications for future research. After reviewing all the articles for eligibility, 68 studies were included. The researchers used a thematic approach to synthesize the data through an iterative process, where steps are repeated and re-evaluated to extract the true meaning. So let's talk about the findings now. 7 themes were identified, which we'll individually discuss. We start with the epidemiology of pain. Studies consistently show a high prevalence of pain among hospitalized children. In Kenya, specifically, there was high prevalence of untreated pain reported by HIV-positive patients. Pain was found to be the leading cause of morbidity among young children in Ethiopia. Children and parents identify procedural pain as the worst cause of pain. 2 studies reported younger children experiencing more procedural and post-operative pain than older children. Neonates often undergo painful procedures with no pharmacological or non-pharmacological management. For chronic pain, data is extremely limited, but one study found that 64% of children with cerebral palsy in Uganda suffered from chronic pain, yet none were receiving analgesics. Health system factors that were identified included knowledge and attitudes towards pediatric pain as found in the literature search. There was a clear knowledge-practice gap. While some nurses showed good theoretical knowledge, unfavorable attitudes or a lack of institutional protocols often prevent this from translating into bedside care. Nurses with an institutional pain management protocol were twice as knowledgeable as their counterparts. Knowledge deficits led to underassessment of pain severity and inadequate pain management. When it comes to education, current nursing and medical curricula are noted to be lacking in specific pediatric pain management training. A Rwandan study suggested interprofessional educational activities to improve shared decision-making between healthcare providers. When it comes to resources for optimal pain management, the authors found that the following factors hindered effective pain management, such as workforce shortages, especially in providing non-pharmacological pain management strategies, unreliable drug supplies, and a lack of pediatric-specific equipment, such as ventilators, which makes clinicians hesitant to use opioids for fear of respiratory depression, limited access to pain literature, power outages, as well as consumable shortages are other examples of resource constraints to providing adequate pain management. In Kenya, nurses lacked IV cannulation skills, which led to them administering morphine intramuscularly instead. Language barriers and cultural differences also play a role in suboptimal pain management, as it impacts understanding between patients and healthcare professionals. Mothers in Kenya were found to be enthusiastic about helping with non-pharmacological pain management strategies, but did not feel empowered to do so. Access to pharmacological treatment. There is a critical shortage of child-friendly formulations. For example, morphine is often only available in tablet form. Innovations such as creating cost-effective child-friendly morphine syrup was an example of how to overcome this. Families frequently have to bear the cost of medications themselves that can contribute as a barrier. System-related factors include supply chain disruptions, drug shortages, budgetary constraints, shortage of pharmacists as well. Barriers to accessing opioids include financial and human resources, poor leadership, as well as complex bureaucratic processes. Even if opioids are available, healthcare professionals' attitudes towards morphine as an addictive agent prevent children from receiving it. But what were the findings on the practice of pain assessment on the ground? The lack of culturally acceptable and contextually validated pain tools was identified as a limiting factor to effective pain assessment in Botswana and Kenya. Across various settings, it was found that routine and consistent pain assessment using scoring tools were not performed. Children admitted with a medical diagnosis were less likely to have their pain scores and analgesia prescribed compared to children admitted for surgical procedures. Pharmacological pain management. When it comes to pharmacological issues, underdosing was found to be a significant problem, particularly for children over 6 years old. Analgesia was underprescribed and under-administered in a study in Kenya, where adults were more likely to be prescribed analgesia, particularly opioids. In a South African secondary hospital, only 10% of children admitted received appropriate analgesia. Timing between analgesia administered and procedure performed varied between 86 and 255 minutes, resulting in severe procedural pain that was worse in younger children. And again, the mention of healthcare professionals' reluctance to use opioids despite evidence of moderate to severe pain. Neonates in Kenya and Ethiopia rarely receive procedural analgesia, resulting in severe pain. 11 studies reported on non-pharmacological pain management strategies, with caregiver presence and distraction considered as helpful. In Nigeria, prayer was commonly used. Virtual reality is effective as a distraction technique during burn wound care or procedures, particularly in older children. Multiple studies describe non-pharmacological strategies to be underutilized due to time constraints and lack of knowledge. The conclusion of this scoping review emphasizes an urgent need to address the treatment gap in pediatric pain management across Sub-Saharan Africa. For nursing practice and institutional development, the authors highlight several critical paths forward. education and training, there is a pressing requirement for increased awareness and specific training for healthcare providers. The authors advocate for the inclusion of context-specific curricula in clinical fellowship programs to empower clinicians to lead systemic change. The study calls for the development and implementation of robust guidelines for pain assessment and management that are tailored to the regional context. Resource allocation. Efforts must be directed toward ensuring the availability of essential analgesics and the resource necessary to administer them safely. Comprehensive research agenda. Future research should go beyond basic observations to include high-quality studies on pharmacokinetics, pharmacogenetics, and non-pharmacological strategies. There is also a specific need for more data on chronic pain and how cultural nuances and belief systems impact pain expression and treatment-seeking behavior. Collaborative action. Improving outcomes for sick children requires a multidisciplinary approach involving not just healthcare professionals and researchers, but also policymakers, educators, and the communities themselves. We have come to the end of this journal club session, but before you leave, take some time to reflect on your own practice. Firstly, how often do you document a formal pain score versus relying on your clinical gut feeling? What are the primary institutional bottlenecks that prevent you from providing optimal pain care on a daily basis? How can you better partner with caregivers to give them active members of the pain management team? And lastly, what are some of the specific barriers to using opioids in children? I hope you have enjoyed this very important topic in caring for sick children. Keep an eye out for the next journal club session. Goodbye.